Thank you very much for inviting me to talk this morning. So we've heard about communicating. Surgeons, as surgeons, we don't really want to, obviously we are trained to learn how to communicate in the operating room relatively well because we have to, or otherwise we couldn't get the operation done. But we typically don't like to communicate when something goes bad because we just want to just put it behind us and forget it never happened. Well, obviously that's not the correct way to address that because we don't really want bad things to happen again. So we've heard about adverse events from Dr. Walsh and how to deal with those. So I'm going to try to bridge those two areas and explain how we can deal with adverse events and try to reduce or improve patient outcomes afterwards so mistakes aren't made again. But how patients are not injured, but also the providers aren't injured too. So I'll start with a case study. So this is a 50-year-old woman, and she underwent a POEM procedure for achalasia. Intraoperatively, she developed a left pneumothorax, and a pigtail was placed. She then became hypotensive. Anesthesia was getting discombobulated about the fact that she was having a pneumothorax, and it had to be placed urgently. So the procedure took a while. The patient came through it. However, she had a barium swallow the next day, and unfortunately, she had an esophageal leak into the chest. She had a repeat endoscopy, more clips were applied to the mucosotomy, but this did not solve the problem. She continued to have a leak, and she subsequently needed major interventions to recover from all this. Eventually, she did recover, but the patient was obviously not too happy about this, but neither were the team members. Not necessarily the surgical team, although they were not happy that this happened, but also the anesthesia team, the nurses, the powers that be. So this is an adverse event. So this is the kind of situation that a root cause analysis would be an appropriate way to deal with this. Now, root cause analyses are commonly applied in business, finance, and other specialties and professions, and it's relevant to us in surgery as well. To remember that the procedures that we do are considered just the index procedures, aside from the complex, multidisciplinary team type procedures. But pneumonectomies and esophagectomies are in the same category as Whipples, as being the most potentially complex or complicated operations that are done by surgeons. So adverse events can happen and will happen. So what is a root cause analysis? A root cause analysis is you have an adverse event, multiple team members and the patient also, but they're not involved in the root cause analysis. Those who are involved need to come together and figure out, why did this happen, who was responsible, or not necessarily who was responsible, because it's not about blaming people. It's about trying to come together and come up with a plan that will prevent this from happening again in the future. So some of the important aspects, of course, are in the root cause analysis are to itemize what happened, the complications, and again, then the team members that were involved, and that is the accountable party, and then implement action items to prevent this from happening again. So you would have a written timeline of events, and then you apply writers or reporters techniques of the W's, right? The who, the when, the where, the how, the why, there's one H in there, and the what. So you want to come up with a list of what was involved in this complication. So it's important initially for the root cause analysis process to have a facilitator. So after the risk management team has evaluated the problem and gone through and come up with a timeline and sort of outlined all these other things, then you all have to come together. The facilitator could be a surgeon who is familiar with the procedure but was not involved in the procedure, someone who's not really supposed to not be biased about how this all happened and trying to, for example, you wouldn't want someone who says, oh, this is my junior partner, they're just learning how to do this. The patient actually did fine in the end, so it's all okay. You don't want someone like that. You need someone who doesn't have any stake involved in this. So the facilitator would be the leader of the discussion. We would have the risk management someone who had put together the timeline and all the W's, and they would be present at this meeting. The surgeon, residents, the anesthesiologist, the anesthesia residents, scrub techs, circulating nurses. Sometimes the biomedical engineer needs to be involved depending on what happened. And of course, it's appropriate to have the OR nurse manager because she or he is in charge of the other OR nurses. And the facilitator will review what is the hospital policy. Was the hospital policy adhered to for whatever, was being done in the operating room, and that what could have, perhaps the hospital policy wasn't followed, and that is the reason why this complication occurred. Was it a staffing issue? Was there not enough people in the room to help deal with this, or enough experienced people to identify a complication, a potential complication, and prevent it from happening? Was there enough supervision, training? Was the equipment working right? So that's maybe where biomed might come in. And then we need to identify an appropriate storyteller. So obviously the surgeon who was engaged in the procedure would have their view of what happened. And maybe they're the most appropriate one to at least say, this is the sequence of events. Of course, they have to remove all emotions and be able to give it as almost like a third-party objective viewer. And then someone needs to be responsible for discussing the roles of all these players. So stepping back, returning to this case, so the root cause analysis of this, when this case was reviewed, the surgeon certainly was one of the accountable parties, but it turns out that so was some of the staff. They weren't familiar with doing this procedure and then setting up the endoscopy, the endoscope, and making the connections and confirming that the connections were correct. And the biomed engineer probably should have been involved in evaluating this to make sure that some of the tubing was right and what was going through that tubing. So one of the factors that impacted this patient's care was that instead of insufflating with CO2, which can be reabsorbed, air was being insufflated and probably was contributing to the development of the pneumothorax and could have resulted in pneumoperitoneum as well. And of course, when you insufflate with all this and you get this, these complications, then the anesthesiologists are upset, and perhaps the surgeon needed to communicate and the team needed to communicate with the anesthesiologist. Look, this is a complication that can happen for this procedure. We need to be aware, we need to be prepared. So there was a fault in the communication between the OR team. So when you do the root cause analysis, it has to be orderly. And the goal, again, is to look forward to try to come up with an action plan to prevent future problems. And we need to have looked at the timeline and see where was the mistake, where was the problem here. And the problem in this case was that, again, the incorrect insufflation gas, in a sense, or air. Instead of using CO2, air was being used. So that was one of the problems. But also, it was a matter of if you're doing a procedure that maybe hadn't been done in the operating room, it wasn't like doing an appendectomy where many, the OR staff would be used to doing this, because it's a relatively routine procedure. But when you're introducing innovative or new procedures in the operating room, you have to make sure everyone's on board, and remember that you're not always going to get the same nurse or the same circulator, and certainly not always going to get the same anesthesiologist. So it's all a matter of trying to remember that it's about communicating, especially when you're introducing new techniques. And then after the root cause analysis is carried out, again led by the facilitator, which isn't necessarily someone from the risk management team, but they were there. You also want to have a facilitator would be typically, again, a surgeon. A corrective plan would be implemented, and that could go back to the risk management or person. It doesn't have to be placed on the physician, who certainly has a lot of other commitments too. So why is this important? It's important because of the second victim trajectory. So the second victim phenomenon was described by an Albert Wu about 20 years ago. And what we see in the second victim is that some who experience this is so the first victim, of course, is the patient in this particular case, and in the cases that we're talking about, adverse events and surgery. But the second victim is other team members, and frequently, obviously, it's the surgeon or physician involved. So there's various stages, and stage 1 is that there's the accident. The accident happened, people are upset, tubes are being placed and not necessarily, or patients are decompensating in the operating room, and so there's chaos. And then the patient has the complication, and then there's the surgeon afterwards is obviously upset about this, and is having a lot of reflection about how negative or fears that they have done something wrong, because perhaps they have, and obviously they should be taking responsibility for it, but it's hard for them to function and go on, because it's not like you do a case and then don't have any other cases to do. You could have a complicated case, but you still have other patients that need to be cared for and other procedures that need to be done. So these intrusive reflections can impact their function on future cases in the immediate period post complication. So the next stage is that the surgeon, in this case, needs to restore their personal integrity. They need to feel like, oh my gosh, I really maybe I shouldn't be a surgeon at all. My colleagues think I am totally incompetent, and they may need some help on trying to figure out that this is an adverse event. There's a way to deal with this. There's a way to identify actionable items so that you can get through this. And again, patients can be protected. And they have to endure the risk management, people coming after them and going through things. And so that can obviously make them feel beat up even more. And finally, after they've gone through all their stages here, the surgeon could either get through it and thrive if they have had the right support and be able to recognize that, okay, this is a problem, but this is how we're going to prevent this problem from happening in the future. Or they may just survive. They may go on, but they may say, oh boy, I just don't think I can do this very well, but this is my job, so I'll get up and do my job again. I got to bring home some money, send the kids to school. So they're just surviving, but they're not thriving. Or they could just drop out. They could say, oh my God, I killed this patient and there's no way I can go on. Obviously, we don't really want to see this. Doesn't help anyone. So a C.R. Denham described in the Journal of Patient Safety many years ago the 5 rights of the second victim. You wouldn't think that the second victim had any rights. It's all about the patient. It is a lot about the patient, of course, but there are, again, second and third victims. So the 5 rights of the second victim, so you're familiar with these, are that the treatment is just, that the second victim is respected, that there's an understanding and compassion for the second victim, that if they need supportive care, that their supervisor or their colleagues can help offer them some supportive care, and that everyone is transparent about the events, and that the second victim is, again, a victim. And why do we care about this? Because physicians and surgeons go through a lot of training, surgeons in particular, because that's what we all are, and we don't want to lose them, because a lot has been invested in this time. And burnout and career satisfaction have been major topics, and as I'm sure many in the room are familiar, the WHO about a week ago came out with a definition, defined burnout as an actual diagnosis. So burnout is a big term here. And burnout and career satisfaction, American surgeons from the study from several years ago, about 10 years ago now, showed that, let's see, go on here. When surgeons are feeling burned out, then it can be because they're not having enough time for their family, that they're just not, their quality of life scores are low, and that it doesn't it doesn't improve their recommendations or advising their family to go on for the career, to pursue careers as surgeons or physicians. So just in summary, remember that there's always, adverse events do happen, but there's a way to deal with them, so that we don't have not only the primary victim, but also the second victims. And the most important thing here is, of course, primum non nocere, Patient comes first, don't first do no harm, but adverse events happen, but you can't just say, así es la vida. No, you have to investigate, you have to debrief. And we do this because we all want to maintain a happy, healthy staff and surgical group so that we can care for our patients and obtain a sense of wellness and accomplishment and satisfaction for what we do. Thank you.